Hello, dear aspirants. Welcome you all to the Master Nursing classes. Yes, good morning. Good morning. Very good morning. So, please share the content with your this class link with your classmates, friends, and colleagues. So, where they can also join to the session. Okay. So, very good morning, students. As all of you know that we are discussing the very important topic sessions for our upcoming RRB and Norcet 8 exams. So, here the conceptual revision classes, the classes that will very much helpful for your RB exams, and those very important questions which are there in the trends. Okay, so the examiner hot topics, those topics we are discussing here in this today's session. So you people will get lots of new knowledge. Okay, so some are the repeated questions, some are the new questions. Okay, some are the updated contents. Okay, please do watch the video till the end, and if you have any minor to minor doubts, so don't hesitate to comment in the comment box. Okay, so yes, if anyone is new to the channel, so do subscribe to the channel, and don't forget to hit the like button, students. Okay, yes, if anyone is new here in this master nursing classes family, so the link of the telegram group is given in the description box and in comment box as well. So you can join to my telegram group as well. It is there in the, yes, the link is there in the description box. Okay, yes, chalo. Okay, before starting the main class, we'll start with one beautiful motivational quote, students. Yes, remember the one word, that is begin again. If you are failing, if you are clearing the prelims and not unable to clear the mains, if you are unable to clear the prelims only, so then no need to worry. Just start to begin again, students. Just remember the one word. Today's what all are the experts there in front of you all? They are also once a beginners. So all today's experts are once a beginners. Okay, once a learners. Okay, so once upon a time they are also have to struggling for understanding the things. Okay, that's what today they are the experts. Okay, so remember that today's experts are once a beginners. So you also don't hesitate to begin. So always, if you are failing the result whatever it may be, okay, so always try to begin again with a good guide. Okay, so with a good content, so that will definitely going to help you crack any kind of the nursing exams. Okay, yes, chalo, without wasting the times, yes, all of you have joined to live session. It will start the class. Okay, so here is the first question in front of you. Yes, read the question. Okay, this is a 5-star question. Okay, the question which is repeatedly asked in each and every exams. Okay, yes, how many extra calories are typically recommended for the lactating woman per day? Okay, so what is the, yes, extra calorie we have to give to the lactating woman. Okay, students, not the question is not related to the pregnant woman. The question is related to the lactating woman, means the question is related to the breastfeeding mothers. So how much extra calories you have to give per day? Option A is that 200 to 300 calories. Option B is that 300 to 400 calories. Option C telling that it's 400 to 500 calories. And option D is telling that it's 500 to 600 calories. Yes, students, yes, fatafat do comment in the comment box. I'm waiting for your answer. Very nice. Yes, that is the option D, that 500 to 600 calories we have to give to the extra to the lactating mother, or else we can say the breastfeeding mother. So my next question is, what is the carbohydrate or the energy level or the calorie level required to the a normal non-pregnant female? So to any non-pregnant female, what is the recommended daily allowance of the calorie? That is, remember, 2200 kilocalorie. Okay, so 2200 kilocalories is the basic calories required for the all non-pregnant woman. In the pregnancy, we will give extra 350 kilocalorie. Okay, so how much it happens? Yes, 350 kilocalories we are given in the pregnancy, means how much it happens? It happens like 2000, yes, 550 kilocalorie we have to give to the, yes, to the pregnant woman. Okay, so then how much extra we have to give? Here we have added the 250, means just 350 we have added in the pregnancy, means just add again 250 here, means extra how much in the lactation to the lactating mother, how much we have to get extra for the lactating mother is the 350 plus 250, that is the, yes, the answer is 600 kilocalories. 600 kilocalories we have to give to the extra carbohydrate to the lactating mother. Hope the concept is clear here, students. Yes. What is the normal kilocalorie we have to give to the non-pregnant woman? That is the 2200 kilocalorie. Then, yes, how much extra kilocalorie we have to give to the pregnant lady per day? That is the 350 kilocalorie. Then in the lactating mother, we have to give the 600 kilocalorie. Okay. Hope the concept is clear. How much total carbohydrate we have to give the, or how much total calories we have to give to the lactating mother means, that is, yes, 2800, okay, kilocalorie. Okay, this is the 2800 kilocalorie is the recommended calorie we have to give to the lactating or the breastfeeding mother. Is this the basic concept you have to all remember? Okay, many times they have asked the question to the non-pregnant woman, many times they have asked a question to the pregnant woman, and yes, many times they have asked a question to the lactating woman. So that's what I have comparatively told all three datas. So what you have to do is, the while solving the question, you have to focus on over the questions. So what they asked a question actually, whether they asked for a lactating woman or the normal non-pregnant woman or the pregnant woman. Based on that, you have to give the answer. Okay, here the answer is the option D is the correct answer. Yes, all of you have marked it correctly. Okay, so here's the next question in front of you. Read the question properly, carefully, then give the answer for this question. Okay, yes, what is the recommended daily intake of the folic acid for a pregnant woman? Again, 5-star questions. Again, 5-star question for you all. Yes, what is the recommended daily intake of the folic acid for a pregnant woman? Okay, yes, to pregnant woman can folic acid ಕೊಡಬೇಕು per day. Okay, yes, how much is the recommended daily calorie intake for the pregnant woman, students? So there is one word, that is the recommended daily allowance. What it means? It means how much nutrition we have to give per day, per one day. Okay, that is what we call as the recommended daily allowance. Okay, yes, yes, many of you giving the B as the answer and some of you are giving the C as the answer. Remember, students, the recommended daily allowance the examiner asking means for folic acid, that is the 500 kilocalorie we have to give. But the question is like this: how much folic acid you have to give in the pregnant lady in order to prevent neural tube defect? Student, just understand the difference. Okay, if the examiner asking the recommended daily allowance of the folic acid per pregnant woman is the 500 microgram, if the examiner asking the how much folic acid you have to give to the pregnant woman in order to prevent the neural tube defect means, you have to give the answer as a 400 microgram. Okay, so yes, so the answer for this question is the, in examiner they have asked the, yes, recommended daily allowance. Okay, recommended daily intake. So the answer is option C goes the correct answer. That is 500 microgram is the recommended daily allowance of the folic acid. Okay, in order to prevent the neural tube defect. Okay, neural tube defect. In order to prevent the neural tube defect, okay, we have to give the 400 microgram of the folic acid. Students, here also there is one basic concept that is very important you have to understand. So what that basic concept? Okay, consider she is the, yes, the pregnant lady. Okay, so I will make a very easy for you all. She is a pregnant lady. Okay, so for this pregnant lady we have to give the folic acid to prevent the neural tube defect. If she is first time pregnant or if she is the primary gravida, okay, if she is first time pregnant or if she is primary gravida, okay, so for her to prevent the neural tube defect we have to give the 400, yes, microgram of the folic acid. Okay, 1 month before the pregnancy and, yes, the 3 months after the pregnancy. Sir, you are telling that we have to start the folic acid 1 month before the pregnancy. How can we know, sir, that the female is going to pregnant? Student, this is possible only in the educated couples and the couples who comes to the, yes, OPD for the planning of the conception. Okay, it is possible only in the planned pregnancy. Okay, so yes, what is the recommendation tells? Recommendation tells this in the primary gravida or who is their first time they are planning to pregnant, for them, yes, we have to give the 400 microgram of the folic acid. Yes, we have to start it 1 month before the pregnancy and 3 months after the pregnancy. This is the basic concept. What if the examiner is giving, yes, multigravida, okay, multigravida with history of neural tube defect. Means she is previously pregnant. This female is previously pregnant and she is having one child of the neural tube defect. She is having the history of the neural tube defect, means the dose of the folic acid changes here from 400 microgram to the, that is the 4000 microgram, or we can say, or directly we can say 4 milligram. Okay, 4 milligram or the 4000 microgram. Then when we have to start, sir, we have to start it, yes, very necessarily 3 months before the pregnancy, and yes, 3 months after the pregnancy. Okay, so before the pregnancy, when we have to start, we have to start 3 months before the pregnancy. Then we have to give till 3 months of the pregnancy, means that is first trimester of the pregnancy. Hope the concept clear. Here the examiner can give the data as a, yes, we have to start it 4 week before pregnancy and 12 weeks of the pregnancy also he can write. Okay, here 12 week before pregnancy and 12 week after pregnancy, means after pregnancy in the sense the 12 week first duration of the pregnancy, means that is the first trimester. Hope the concept is clear. Okay, let's quickly revise the concept. What is the dose of the folic acid to prevent the neural tube defect? Yes, that is the 400 microgram. What is the dose of the folic acid to prevent the neural tube defect in a female with history of the neural tube defect? That is 4000 microgram. When we have to start the neural folic acid in a primigravida or the pregnancy, the female who comes for the first time pregnancy plan. So we have to start 1 month before the conception. Then we have to give till the 3 months of the conception. Okay, yes, 3 months after the conception. Then in a female with history of the neural tube defect, we have to start the 400 for 4000 microgram of the folic acid or the 4 mg of the folic acid 3 months before the conception, and we have to give the 3 months after the conception. This is to prevent the neural tube defect. I am telling the dose of the folic acid. Students, remember, iron should not be given in the first trimester of the pregnancy. Okay, so because iron is a it generates a free radical and it may damages the growing fetus. So iron we will consider as a teratogenic for the first trimester of the pregnancy. So don't give the iron in the first trimester of the pregnancy. We will start the iron from the second trimester of the pregnancy. Okay, that is the 60 mg of the iron plus 500 mg of the folic acid. In the anemia mukta bharat program, we will start from the second trimester or after the third month of the pregnancy. Okay, this is the basic concept you have to know. Here we have discussed all the possible questions that is related to the folic acid. Okay, hope the concept is clear. Yes, so this one particular questions will clear your thousand of the doubts. Okay, yes, is that clear? What is the recommended daily intake of the folic acid for the pregnant woman? Means that is the 500 microgram. In order to prevent the neural tube defect, 400 microgram. Okay, so my question is, how much vitamin D we have to give to the pregnant woman? Means for the pregnant woman, recommended daily allowance of the vitamin D is the 10 microgram, or we can say the, yes, the 40 international unit of the vitamin D we have to give to the, yes, the pregnant woman. Okay, what if the question is asking that, yes, how much calcium we have to give to the pregnant woman? Yes, how much calcium we have to give to the pregnant woman? Yes, the calcium recommended dose for the pregnant woman is the 1200 milligram of the calcium we have to go to the pregnant woman. Okay, so the examiner can also give the 1.2 gram of the, yes, calcium. Okay, so students, remember, in the question they related to the calcium, they will make a twist, like the calcium in postmenopausal woman is very important. Okay, postmenopausal woman is very important, and calcium in the pregnant woman also very equally important. Okay, yes, why postmenopausal woman? In postmenopausal woman, because of the decreased estrogen, the bone density will decreases and there is highest chance of the osteoporosis. Because of that, for the menopausal woman or the after the menopause, we have to give the calcium. The examiner asking the question like, what is the dose of calcium in the postmenopausal woman? Means we can say that 1 gram per 1 day. Okay, so or we can say that 1000 milligram per 1 day. So this is the dose in the postmenopausal woman. What if the examiner asking the questions on the recommended daily allowance of the calcium in the pregnant woman? In the pregnant woman, it is 1200 milligram, or we can say this one is the 1.2 gram per day. Okay. So remember students, in the question you have to focus. So the calcium dose is asking related to, yes, in related to postmenopausal or in related to the, yes, pregnancy. In related to postmenopausal, the dose is changed here. That is the 1 gram per 1 day or the 1000 milligram per 1 day. In related to pregnancy, the dose is different. There is a 1200 milligram per day or 1.2 gram per day is the recommended dose of the calcium. Okay. Yes. Is that clear? Clear. So then what is the recommended dose of the iodine in the pregnancy? That is the 250 microgram is the recommended dose of the iodine in the pregnancy. Okay. Yes. How much iodine is required in the pregnancy? That is the 250 microgram is the iodine required in the pregnancy in order to prevent the goiter in the pregnancy. Is that clear, students? Clear. Okay. So then what is the answer for this question? This question answer is the option C. There is the 500 microgram is the RDA for the folic acid. So hope the concept is clear here. Okay. Let us quickly revise the answer for the previous question. Yes. Let us quickly revise the answer for the previous questions that you people can, yes, go for the next question. Okay. So what is the recommended daily allowance of the vitamin D in the pregnancy? That is the 10 microgram or 40 international unit per day. Okay. What is the recommended daily allowance of the calcium in the pregnancy? That is 1.2 gram or the 1200 milligram. Okay. Then what is the recommended dose of the iodine in the pregnancy? That is 250, yes, microgram. Okay. Then what is the recommended daily allowance of the folic acid in the pregnancy? We have studied in detail. That is the with history of the neural tube defect 4 milligram or the 4000 microgram. Okay. Without history of the neural tube defect, that is the 400 microgram. Hope the concept is clear. The RDA for the folic acid is the 500 microgram. Is that clear? Clear? Yes. Definitely. I am telling definitely one questions will directly print from my word in your RRB question paper. Okay. It will give definitely 1 marks for you. Okay. Yes. Chalo. Next question. Here is the next question in front of you all. Yes. Read the question carefully, properly, then give the correct answer. What is the question here? What is the recommended weight gain during the pregnancy for a woman with a normal body mass index? So, for the woman with normal body mass index, how much weight gain occurs in the pregnancy? Yes. So, I am waiting for your answer in the comment box, students. Yes. Keep it one fresh notebook and pen with you all and write on that one the master nursing classes bullet points. Okay, before your exams, revise these bullet points. It will strike your rank in the uh, selection list. Okay. Yes. Clear? Yes. The answer for this question, I'm waiting for your answer for this question. Yes, very nice of you all. What is the recommended weight gain during the pregnancy for women with normal BMI? Yes, I have given in the weight in the kg means all of you would answer here. Yes, it is the pound. Just I will give a clue for you. Yes, 1 kg is equal to 1 kg is equal to how much pound? That is the 2.2 pound. Okay. For pounds we can write the LB. Okay. 1 kg is equal to 2.2 pounds. Yes. Clear? Yes. Just try to give answer now. Very nice of you all. The answer is yes. Option C is going the correct answer here. That is the 22 to 33 pounds. We can remember. Okay. So the single best answer is the 24 pounds. Okay. What is the single best answer? That is the 24 pounds is the single best answer for this question. Then in kg, how much, sir? Then in kg is the, yes, the range of the weight gain during the pregnancy is 10 to 12 kg. Okay. The single best answer is the 11 kg. Okay. So multiple 11 into 2.2. That is the, yes, nearly 24 it will come. So the 24 pounds is the, yes, the weight gain normally occurs in the pregnancy with a normal body mass index. Hope the concept is clear here, students. Yes, very nice of you all. Okay. Here is the next question. Read the question carefully, properly, then give me the proper answer for this question. Yes. Chalo. The question is very simple. Excessive weight gain during the pregnancy can indicate, yes, which of the following? Okay. Excessive weight gain in the pregnancy can indicate which of the following condition. Option A is that the gestational diabetes. Option B is that preeclampsia. Then option C is that polyhydramnios. Then option D is that, yes, all the above. So I want answer for you all. So the pregnant woman excessively gained the weight. Okay. During the pregnancy. So then what it indicates? So first, just try to tell me what is the excessive weight gain in pregnancy. Students, in the pregnancy, the female should gain the weight that is 0.5 kg for 1 week. This is normal. or we can say less than 2 kg per 1 month. Okay, this is the normal. Okay, this is the normal. If in case the female is gaining the weight more than 2 kg in 1 month, okay, more than 2 kg in 1 month, so that indicates the excessive weight gain in the pregnancy. Okay, so there is lots of weight gain, excessive weight gain in the pregnancy means what it indicates. Yes, very nice of you all. That is the yes, all the above goes the correct answer. How the gestational diabetes leads to the excessive weight gain in the pregnancy? Yes, how means it is very simple. Yes, so gestational diabetes. Okay, what happens in the gestational diabetes mellitus? So the because of the HPL hormone, that is the human placental lactogen, okay, excessively causes the resistance to the insulin. Okay, this hormone, the human placental lactogen, excessively causes resistance to the insulin. So this resistance excessively increases the blood glucose level. Okay, so blood glucose level will be increased in the gestational diabetes mellitus. So the increased blood glucose level goes to increased blood glucose level, yes, supplies increased glucose to the fetus. Okay, so yes, what happens? Increased glucose to the fetus. So in the fetal blood there is excessive glucose means, yes, the osmolality of the fetal blood will increases and the extracellular fluid of the fetus shifted to the intracellular of the, yes, sorry, extracellular to the intravascular, it will shift. So increased intravascular fluid in the fetus, yes, increased blood supply to the fetal kidney, so increased urine output in the fetus. Okay, increased urine output in the fetus. So this increased urine output in the fetus, yes, what is the main source of the amniotic fluid? That is the urine of the fetus. So increased urine of the fetus means increased amniotic fluid. Increased amniotic fluid means it causes the polyhydramnios. Okay. Yes, two concepts clear here. In the gestational diabetes mellitus, weight gain occurs and the polyhydramnios also occurs because of the increased urine output to the fetus. Okay, means increased polyhydramnios. What is the polyhydramnios? Poly means more, hydro means yes the water, that is the amniotic fluid water, yes, increases, yes, more than 25. Okay, so that is the amniotic fluid index. We have the amniotic fluid index. So in the amniotic fluid index, the normal amniotic fluid index is that is the 5 to 25 is the normal amniotic fluid index. If the, yes, fluid amniotic fluid index is less than 5, we call that one as in the oligohydramnios. If the amniotic fluid index is more than 25, we call that one as the polyhydramnios. In the polyhydramnios, excessively amniotic fluid amount will increases more than 2 liter. Okay, in the oligohydramnios, yes, the amniotic fluid index level comes to below the 5. Okay, that is what we call as in the, yes, the oligohydramnios means the amniotic fluid index comes below 5. Okay, polyhydramnios means the amniotic fluid index comes above the 25. Okay, is that clear, students? Yes, it is very clear. Okay, so yes, as I told here, in the gestational diabetes mellitus, the polyhydramnios occurs means the amniotic fluid increases means the weight gain also occurs. And the baby of the gestational diabetic mother is the, yes, macrosomic baby means, yes, the baby size will be more than 4.5 kg. Okay, so that is what we call as in the macrosomic baby. How means, students, remember here there is excessive insulin production in the baby. How the excessive insulin production occurs? Because I told the lot of blood glucose which is supplying to the baby, increased blood glucose in the mother. Okay, so increased blood glucose in the mother, okay, increased supply to the blood glucose to the fetus. Okay, this fetus increases the, yes, insulin. This fetus increases the insulin. Okay, remember the growth of the fetus occurs by the insulin and insulin like growth factors. Students, growth of me and growth of you occurs by the growth hormone, but growth of the fetus means the baby which is present in the uterus of the mother, that is what we call the fetus. The growth of the fetus occurs by the which hormone means the growth of the fetus not occurs by the growth hormone. The growth of the fetus occurs by the insulin means the blood glucose level supply is lot to the baby, so the insulin also production is lot in the baby. So that is because of the increased insulin in the fetus, so the fetus will grow more, so the macrosomic baby will be born to the, yes, the mother of the gestational diabetes. Okay, so because of the macrosomic baby, because of the polyhydramnios, weight gain occurs in the, yes, weight gain occurs in the gestational diabetes. Okay, so then polyhydramnios also weight gain occurs. Then what is the preeclampsia? Preeclampsia is a condition. Okay, so in this particular conditions there is a excessive proteinuria will be there, means in the urine of the mother the protein will get lost. Okay, because of that the edema occurs. Because of that the edema occurs in the preeclampsia. This edema again leads to the weight gain. Okay, Again, this leads to the weight gain. Yes. So how many questions we have studied in this particular one single question? Yes, the gestational diabetes mellitus means this occurs due to the resistance to the human placental lactogen HPL hormone. Okay. So that HPL hormone causes the resistance to the insulin, which leads to gestational diabetes mellitus. And in the gestational diabetes mellitus, polyhydramnios occurs. This is also we have studied. Okay. So then after that, next question is, so in the mother of the gestational diabetes mellitus, the baby or the fetus will be the macrosomic. Then macrosomic means the big baby. Microsomic means the small baby. Okay. So yes, the macrosomic baby will be born to the gestational diabetes mellitus. Then what we have studied, the normal amniotic fluid index, that is the 5 to 25 is the normal range of the amniotic fluid index. If the amniotic fluid index more than 25, that is the polyhydramnios. The amniotic fluid index less than 5, that is the oligohydramnios. We have studied the basics here. Okay. Yes, is that clear? Clear. Okay. So yes, here is the next question. The answer for this question goes to the option D as the correct answer. That is the all of you have marked it correctly. Very nice of you all. Okay. Yes, that is the correct answer. That is the all the above. Okay. So here is the next question. Read the question carefully, properly. In each and every question, I am discussing the 10 more questions related to that particular questions that may directly strikes in your exams. Okay. Is that clear? Yes. So here is the next question. What is the primary cause of the physiological edema in the pregnancy? Okay. What is the primary cause of the physiological edema in the pregnancy? Yes. Option A is telling that the decreased plasma protein level. Option B is telling that the decreased capillary permeability. Option C is telling that the decreased cardiac output. And option D is telling that the increased blood viscosity. What happens in the pregnancy? What is the cause of the physiological edema in the pregnancy? Yes. What happens, students? I am waiting for your answer here. Yes. Option A is the decreased plasma protein level. Is this occurs? Option B is the decreased capillary permeability. Is this occurs? Option C is the decreased cardiac output. And option D is the increased blood viscosity. Yes, it occurs because of the decreased plasma protein level. Remember, students, if I check the albumin and globulin in my body, yes, the ratio between the albumin and globulin in my body is the 1 is to 1.7 is to 1. Means my albumin is more than my globulin. But as I check the albumin and globulin ratio in pregnancy means that is 1 is to 1. Okay. How it occurs 1 is to 1? So consider this is the blood with albumin or the fluid with albumin, and this is the fluid with the globulin. Okay. Yes, fluid with the globulin. Consider this one. Okay, let me make a proper diagram so you people can understand it very easily. Okay. So that is what actually helps in the exam. Okay. Yes. So this is the bottle of the or the container of the globulin, and this is the container of the albumin. Okay. In the non-pregnant cases or in the all healthy humans, the albumin will be high. Okay. Albumin will be high and the globulin will be low. Okay. So as the albumin will decrease to this level and as the globulin will increase to this level, means in the pregnancy the amount of the globulin in the pregnancy increases, means the amount of the albumin in the pregnancy get decreases. Okay. And the ratio between the albumin and globulin become equal, so that is 1 is to 1 is the ratio in the pregnancy, that is between the albumin and globulin. So as I told, albumin is decreasing means the plasma oncotic pressure will decreases. Okay. And in addition to that, there is 6.5 liter of the fluid retention in the body of the pregnant woman. Okay. So in the pregnant woman body, how much of the fluid will get retained? Yes, that is the 6.5 liter of the fluid will get retained in the pregnant woman. So increased amount of the volume of the fluid plus reducing the amount of the albumin which leaks the fluid in the interstitial space. So that may leads to the physiological edema. So what the physiological edema actually stands? Physiological edema is the normal, students. In all pregnant women it happens. Okay. So how we have to identify the physiological edema? Students, remember, so this is the foot of the female of the pregnancy. Okay. So the edema occurs with this level. Okay. So that is just below the ankle. The physiological edema will never go behind the ankle. Okay. So it is most commonly occurs in the lower extremities, and it is below the ankle only, not above the ankle. One thing. Okay. So second point we have to say the physiological edema is that, so if you give the elevation to that limb or the rest to the pregnant female, so it will relieve. Okay. So rest will relieve the physiological edema. If even after giving the rest, the edema is not resolving, means that is the pathological edema. That may be because of the preeclampsia or the eclampsia. Okay. Is that clear? Yes, it is very importantly and it is very necessary. Yes. So what all are the things we have learned here? Yes, the amount of the albumin in the pregnancy decreases, amount of the globulin in the pregnancy increases, the ratio between the albumin and globulin in the pregnancy is equal, that is the 1:1. Okay. So non-pregnant or pre-pregnant state, the ratio between the albumin and globulin is the 1:7:1. Okay. So then amount of the fluid increases in the pregnancy, that is up to the 6.5 liter of the fluid retention will be there in the pregnancy. Okay. So because of the decreased plasma protein level and in addition to that increased blood volume level, there is chance of the physiological edema. How we have to characterize the physiological edema? Physiological edema is restricted to the below the ankle. Okay, it will not crosses the ankle, and physiological edema relieves by the rest and relieves by keeping the that's lower extremities in the elevated position. Hope the concept is clear here. Yes, the option A is the correct answer for this question. Is that clear, students? Yes. So is that cardiac output decreases in the pregnancy? No. So there is increased cardiac activity in the pregnancy. Okay. So the cardiac output will increases because, as I told, the amount of the fluid increases, means amount of the cardiac returns to the heart will increases. That will lead to the increased cardiac output happens in the pregnancy, not decreased. So I am eliminating this option. So increased blood viscosity occurs. What is the blood viscosity? Viscosity means we can say the Ghadapanti. Okay. So yes. So is the blood viscosity will increases or decreases in the pregnancy? Students, as it told, yes, there is retention of the fluid up to the 6.5 liter, means the entire blood of the female will get dilute, means diluted blood means yes, the decreased viscosity of the blood will be there. Okay. So is that clear? So decreased viscosity of the blood will be there. Okay. So there is no increased viscosity of the blood. Hope the concept is clear. And there is increased cardiac output, decreased viscosity of the blood. Okay. And decreased plasma protein level will be there in the pregnancy. Hope the concept is clear for this question. Yes, I am moving forward to the next question. Here is the next question in front of you. Okay. Yes, how many extra calories generally recommended for the pregnant woman? Yes, we have already solved this question. Yes, that is the how many. Yes, give the answer. Yes, I will see how many of you have seen the first question properly. Let's give the answer for this question. Very nice of you all. So what I told, that is the 350 kilocalorie extra we will give. Okay. So just try to put the 350 kilocalorie in this given option and give the answer. Option A is telling 100 to 200 kilocalorie per day. Is this correct? No, students. It will get less. So 200 to 300. I told we have to give the 350. So is there 350 belongs between this one? No. So this is also not of my answer. So my 350 kilocalories belongs to between the 300 to 500. So yes, the answer for this question is the yes. That is the in range we have to give the 300 to 500 kilocalories per day to the pregnant woman. One single best answer is the 350 kilocalorie we have to give additionally to the pregnant woman. Already discussed the question. Okay, here is the next question. Yes, all of you have given the correct answer. As you see, that is the properly 100% correct question. Okay, so here is the next question. Read the question properly, students, then try to give the best answer. Yes, what is the primary role of the progesterone during the pregnancy? Option A is that it is telling the stimulates the uterine contraction. Is that progesterone stimulate the uterine contraction? Yes. Think once before giving the answer. Then option B is the maintains the endometrium. Then option C is that increased breast milk production. Then option D is that inhibiting the pregnancy. Yes, I'm waiting for your answer, students, here. So apply the method of elimination. You will getting the answer very much easily. Students, progesterone is the main hormone, okay, which is acts as a smooth muscle contraction. Okay, all smooth muscles it will get relaxes. Sorry, it is acts as a smooth muscle relaxant. Okay, all the smooth muscles in the uterus or in the other part of the body will be get relaxed in the pregnancy because of the our beautiful hormone what we call as in the progesterone. Progesterone is the smooth muscle relaxant. As all of you know that this is the uterus and the middle layer of the uterus is the myometrium, and in the myometrium we are having the smooth muscles. Okay, so during the labor process these smooth muscles only get contracts here. Okay, so whenever there is a contraction of these smooth muscles means the product of conception which is there in the uterus will comes out. Okay, yes, it not happens because of the progesterone keeps these smooth muscles to relax. Okay, so it keeps these smooth muscles to relax. And yes, the main hormone which is responsible to maintain the pregnancy is the progesterone. Remember the question, repeatedly asked question, the main hormone which is responsible for maintaining the pregnancy is the progesterone. Okay, why? Because the progesterone acts as a smooth muscle relaxant on the uterus. So option A is telling that it stimulates the uterine contraction. No, it makes the uterine to get relaxed. So my option A is the get eliminated here. Okay, so then what is the option B is tell? So keep it that one beside, and we'll go for the option C. Okay, it increases the breast milk production. Students, yes, what is the galactokinesis? What is the galactopoiesis? Now tell me the answer. Yes, what is the galactokinesis? What is the galactopoiesis? I will tell the definition. You write it is the galactokinesis or the galactopoiesis. Yes. Yes. Can I tell the definition? Yes. So the process of production of the milk in the presence of the prolactin hormone. Process of production of milk by the prolactin hormone. Okay. What we call this one? Galactopoiesis or the galactokinesis. Yes, wherever the word it comes as a poiesis means there is something production will be there. Okay, so we can say the erythropoiesis, the process of production of the red blood cell, that is the erythropoiesis. Here, the galactopoiesis. Galactopoiesis means the process of production of the milk. Okay, so what is the hormone which is responsible for the process of production of the milk is, yes, the production of the milk occurs in the presence of the, yes, the prolactin hormone. Okay, so which hormone it maintains the, yes, which increases the breast milk production, that is the prolactin hormone. Okay, so option C is also not our answer, because the breast milk will be produced with the help of the prolactin and not because of the progesterone. So option C also I have eliminated. Then come to the option D. It inhibits the pregnancy. No, students, as I told, it acts on the endometrium of the uterus. Sorry, it acts on the myometrium of the uterus, and it makes the uterus to keep relaxed. Means that it maintains the pregnancy. It will not inhibits the pregnancy. So the main hormone which maintains the pregnancy also again progesterone. So remaining one option, that is the, it maintains the endometrium of the pregnancy. Okay, so what we call the endometrium of the pregnancy, bachcho, the endometrium of the pregnancy, the inner layer of the uterus in the pregnancy, that is what we call as in the decidua. What we call this in the, yes, the decidua. Okay, so I will tell three more questions on the decidua. You have to remember that one. So whatever it may be the structure which is coming just before the pregnancy and going shedding out after the pregnancy. So that is what we call as the decidua in the pregnancy. Okay, so the endometrium of the pregnancy we call the decidua, because the endometrium completely shed out after the pregnancy, means it will goes away from my body, means that is what I call decidua. Means whenever we were kid, okay, so at that point of the time we were having the teeth in our mouth, so that teeth naturally it will decays out. Okay, means it will comes out. So those temporary teeth I call the decidual teeth. Means what is the decidua? Decidua means it is going out of the body. Okay, that is what I call the decidua. Okay, so I will tell the placenta as a decidual organ. So why I have to tell the placenta as a decidual organ? Because students, immediately after pregnancy, okay, so the placenta also getting delivered in the third stage of the labor. Okay, means the placenta also going out of the body. So I call the placenta as a decidual organ. Okay, so decidua means which goes out of the body. Is that clear? It is a simple meaning in the medical system, that is the decidua means which goes out of the body. So simply the question will be asked like this: what we call the endometrium in the pregnancy. So endometrium in the non-pregnancy we call the endometrium, but the endometrium, the inner layer of the uterus in the pregnancy, we call that one as the decidua. Is that clear? Yes, clear. Okay, so yes, the next question is very simple, and the answer for this question is that it maintains the endometrium or it maintains the decidua is the correct. The hormone which is responsible for maintaining the decidua is also a progesterone. Hope the concept is clear. In this particular question, we have discussed the, yes, the 5 to 6 more questions, that is very much helpful for you all. Okay, yes, the galactopoiesis will be the production of the milk, and the galactokinesis is the expulsion of the milk. So expulsion of the milk or the ejaculation of the milk will be done by the oxytocin hormone, and the production of the milk which is done by the our prolactin hormone. Okay, so is that clear? Okay, production of the milk is the galactopoiesis, and yes, the process of ejaculation of the milk is called as the galactokinesis. Means kinase means here as the movement. Okay, simply we have studied in the our physics. Okay, kinetic movements. Kinase means there is no movement. Okay, so movement of the milk from the ducts to from the nipple to the baby of the mouth. So that is what we call as in the ejaculation of the mouth milk. That is ejaculation of the milk. So yes, that is what we call as in the galactokinesis. It occurs because of the in the influence of the hormone, that is called as the oxytocin. Hope you all know this answer. Okay. Yes. Is that clear, bacho? Yes. Very nice of you all. We will go for the next question. Yes. So next question is very simple here. Yes. Read the question properly. Then give your best answer for this question. So what is the role of the estrogen during the pregnancy? Very simple question again. And keep this question as a 5-star question. Okay. It will definitely strikes. And the few more questions which will comes out of this concept will definitely strikes in the exams. Whether it may be a Norcet means, it may be Norcet prelims or your RRB exams, it definitely strikes. Okay. So what is the role of the estrogen in pregnancy? Yes, option A is that the promote the uterine contraction. Option B is that it increases the clotting factors. Option C is that it increases the insulin resistance. Option D is that it enhances the fetal growth. Okay. Almost 3 points from here we have already discussed. Okay. Almost 3 points from this point we have already discussed. Okay. So again I will go for the method of elimination. So that may be practicable for you all. Okay. So it enhances the fetal growth. As it told, in the womb of the mother, the baby is growing. Yes, with the help of the insulin like growth factor. Okay. Or I can directly say that is the insulin of the fetus. Okay. Not by the insulin of the mother. Students, remember, insulin will never ever cross the placenta. Okay. So two things always you have to remember: heparin and insulin will never ever crosses the placenta. Okay. So placenta also, sorry, insulin also not crosses the placenta. That is why the drug of choice in the, yes, the gestational diabetes mellitus is the insulin. Okay. Not any metformin, glimepiride, okay, uglibos. So no oral medication will be encouraged in the pregnancy. Okay. The drug of choice for the gestational diabetes mellitus is the insulin. Your clear and perfect answer, and drug of choice is the insulin. Okay. Why? Because the insulin will not crosses the placenta and there is no any teratogenic effect on the fetus by the insulin. Okay. But as I told, the increased blood glucose level to the fetus itself produces the excess insulin. Because of that, in the pregnant gestational diabetes mother pregnancy, there is macrosemic baby will be there. Okay. As the fetal growth will be enhanced by the which hormones, that is the insulin like growth factor, and insulin is the responsible for the growth of the fetus in the intrauterine life. Okay. Is that clear? Then option B means the answer is not this one. Okay. Estrogen is not responsible for the fetal growth. Then option B is that increased insulin resistance, as I told just in the last question only. Yes, this is done by the human placental lactogen, or we can say this one as in the human chorionic. Yes, human chorionic, not gonadotropin, it is somatotropin. Okay. Human chorionic gonadotropin is different thing, that is the HCG. That is very much different thing. I will discuss that one also. Okay. Don't worry. So human placental lactogen, also we call this one as in the human chorionic somatotropin. Okay. This is responsible for the resisting the insulin in the pregnancy. Okay. This is responsible for the resisting the insulin in the pregnancy. Okay. Yes. Is that clear? Then option A is that yes, it promotes the uterine contraction. Bacho, yes, it may helps for the uterine contraction. Okay, during the process of the labor, during the process of the, yes, labor. Okay, not during the, yes, not during the process of the pregnancy. So in pregnancy, it will not contract the labor. It helps the labor during, sorry, estrogen is responsible for the, yes, contractions during the process of the labor. It helps the oxytocin, not it is directly related to the contraction. Okay. So estrogen helps the oxytocin to maintain the effective contraction. Okay. But option A is telling it promotes the uterine contraction. No, it will not promote the uterine contraction. Okay. During the pregnancy. So option A is also eliminated, option C also eliminated, and remaining is the one, that is the, yes, option B, that is the increased clotting factor. So increased clotting factor is the correct answer, students. Remember, because of the, in the influence of the estrogen, in the influence of the estrogen, all clotting factor increases in the pregnancy. Okay. So because of the estrogen effect, all clotting factor will increase in the pregnancy. Okay. So because of that, yes, there is a statement, the pregnancy is a state of the hypercoagulation. Okay. So there is highest chance of the hypercoagulability in the pregnancy because of the estrogen. Because of the estrogen, there is increased clotting factor. Okay. Increases in estrogen increases the clotting factor. This clotting factor makes the pregnancy is a hypercoagulation state. So because of that only, anticoagulant are much more necessary in the, yes, pregnancy. So in the first trimester we will give which anticoagulant, that is heparin. Okay. In the second trimester we will give which anticoagulant, that is the warfarin. Again in the third trimester we will come for the heparin. Okay, so I will discuss this in detail. Okay, so remember, just in the first pregnancy we will give heparin because heparin will not cross placenta, and in third trimester we will give the heparin because heparin is a weak anticoagulant. If the mother suddenly enter into labor, means it will not cause the that kind of the bleeding, because the warfarin is a strong anticoagulant. It will be very much heavily it will bleeds if the mother taking the warfarin and she gets the labor pain, means. Okay, so that is what in the first trimester and third trimester heparin given, and in the second trimester warfarin is given. I will discuss in this particular concept separately. Okay, don't worry. Yes, is that clear? So remember the one concept by this question. Yes, increased clotting factors occurs normally in the pregnancy. Okay, all the clotting factors we have the, yes, the 12 clotting factors, among those all increases except, sorry, we have the 13. Among 13, one is unknown. Okay, yes, so all the clotting factor will increases except 11 and 13. So this 11 and 13 clotting factors so remains normal. Okay, number 11 and number 13 clotting factors remains normal. Rest all clotting factor will increases in the pregnancy. Hope the concept is clear. Yes, very nice of you all. Okay, so here is the next question. Yes, I'm waiting for your answer in the comment box. Okay, so yes, do comment your answer in the comment box. So what is the cause of the color changes observed in the Chadwick sign? Yes, what is the cause of the color changes we observed in the Chadwick sign? Option A is that increased progesterone level. Option B is that increased blood flow to the blood flow and vascularization. Option C is that is the decreased estrogen level. Then option D is that increased luteinizing hormone, that is the LH. So which of the following is responsible to make the, yes, the Chadwick sign? So first of all, we have to remember what is Chadwick sign. So then only you can able to answer this one. Yes, the Chadwick sign is, yes, I will give the mnemonic to remember the Chadwick sign. So you have to remember the Chadwick sign C and C and C. Okay, so that is the Chadwick sign. C is a color, C is a change. Then again C, that is the cervix. Okay. Yes. Is this tricks is easy for you all? Yes, that is the Chadwick sign. Color changes for of the cervix. Okay, so what, which color changes? Yes, the it is normally a uh, bluish discoloration of the, yes, our cervix in the pregnancy. Okay, so that is what we call as in the, yes, Chadwick sign. Okay, why the Chadwick sign occurs? Because of the increased this is the cervix. Okay, so yes, this is the vagina and this is the cervix. Okay, this one is the exocervix. Outside cervix is the exocervix, and this inside cervix is the endocervix. Okay, so this cervix is the endocervix, and this outside cervix is the cervix towards the vagina is the exocervix. Okay, because of here increased the vascularity, means, yes, the increased blood vessels at the site of the cervix. Okay, so that is what we call as it makes the, yes, change in the color of the cervix to the bluish discoloration. So we call this one as in the Chadwick sign. Okay, where is the option? There is the increased blood flow to the and vascularization to the cervix. There is increased blood flow, and to the cervix there is highest vascularization. So that makes the cervix to change the color. So that is what we call as in the Chadwick sign. If this cervix becomes soft, means what we call this one as the softening of the cervix is also called as the Goodall sign. Okay, what is Goodall sign in the pregnancy? Yes, the Goodall sign in the pregnancy is that yes, softening of the cervix is called as the Goodall sign. Then change in the color of the cervix, we call this one as in the Chadwick sign. Okay, when the Chadwick sign will occur, Chadwick sign will occur at the 6 to 8 weeks of the pregnancy. In the first trimester only, 6 to 8 week of the pregnancy, the Chadwick sign will be seen. Okay, is that clear? Clear, students? Yes, very nice. So some of you have given the correct answer already. That is the, okay, increased blood flow and vascularization is the correct answer. So it helps for the, yes, this is the responsible for the change in the color of the cervix. Hope the concept is clear. And here is the next question in front of you. Yes, what is the primary function of the Montgomery tubercles during the pregnancy? So first you have to know the what is Montgomery tubercles. Montgomery tubercles are the modified sebaceous glands in the breast. Students, this is the structure of the breast. Okay, so in this breast you can able to see this small nodules here. Okay, so these are the sebaceous glands. Okay, these are the sebaceous gland. Okay, so this sebaceous gland will get large during the pregnancy. So these sebaceous glands will secrete the oily material. Okay, So this secretes the oily material, okay, which act as a lubricant, okay, which acts as a lubricant. Students, if you take your finger and dip in the water for a period of the 30 minutes, then after that you have to see your finger. So your finger will be purged, like it will be soft, it will be white, and it will be like skins are like folded. So that is what we call the purging of the finger. Remember, in a day 12 to 15 times the baby will feed the mother breast, okay. It will hold the baby mother breast in the mouth, means in the wet area the breast will be there for the 12 to 15 times. That is the duration of the 13 minutes, okay. 15 minutes to 13 minutes or the 20 minutes, okay. So continuously, so mother nipple or the baby's area will be in the mouth of the baby only, okay. So that may leads to the crack the nipple, but the mother's nipple will not crack. Why? What is the reason? What is the reason is very simple, because of the we are having the sebaceous gland, okay. So which secretes the oily material and which makes the lubricant, and it prevents the, yes, cracking of the nipples, okay. It prevents the cracking of the nipples. So this modified sebaceous gland in the pregnancy, we call this one as in the Montgomery tubercles. Okay, hope you are understand. And in each and every breast, so there is 5 to 15 Montgomery tubercles will be there in one single breast. Okay, is that clear, students? Yes. What is the primary function of the Montgomery tubercles? Yes, that is the secretes the lubrication is the primary function of the Montgomery tubercles. Okay, it helps to prevent the, yes, cracking of the nipples, okay. So it helps to prevent the cracking of the nipples. If in case this Montgomery tubercles are absent, okay, this Montgomery tubercles are absent, means the cracking of the breast nipple will occurs, okay. So breast nipple crackers will be occurs, okay. So this may sorry, let me write it properly. Yes, the cracking of the breast nipple will occurs, okay. So then what is the nursing management? What is the nursing management? So just we have to advise the mother to apply, to expel some milk and apply around surround of the breast after each and every feeding, then expose the areola to the air, okay. So we will advise the mother to expose the nipple, the cracked nipple, and expose areola to the fresh air, okay, fresh environmental air we will advise to expose. So that may helps for the reducing the crackles of the nipple, okay. Is that clear? So that is also asked in exam, so extra point I have told here, okay. So answer for this question is the primary function of the Montgomery tubercles. As if you have given the correct answer, that is the, it secretes the lubricant, and these are the modified sebaceous glands on the breast. The number of the Montgomery tubercles are 5 to 15 on each breast, okay. So the function also I have told already, okay. So here is the next question in front of you all. Yes. So what is the primary cause of the linea nigra? Yes, what is the primary cause for the linea nigra? What is the linea nigra, students? Can anyone able to tell the definition of the linea nigra? Yes, try to give the answer for this question. We will then go for the what is the linea nigra. Okay. So what is the primary cause of the linea nigra? Option A is the iron deficiency. So iron deficiency leads to the anemia, not linea nigra. So which may leads to the anemia. Okay. So iron deficiency plus folic acid deficiency in the pregnancy. So both. We call this one as a dimorphic anemia. Yes, students. So what is di? Di means two. Morphic means two morphologies. Anemia means which morphology? One morphology of the iron deficiency anemia, one morphology of the folic acid deficiency anemia. So iron plus folic acid deficiency anemia, we call this one as in the dimorphic anemia. Okay. Yes. So this will not lead to the linea nigra. Yes, option A. Option B is that increased increased melanin production due to the hormonal changes. Yes. Option C is the stretching of the skin. Option D is the calcium deficiency. Okay. So calcium deficiency which leads to the osteoporosis and hypocalcemia and the hypocalcemia, and that may lead to the, yes, the spasm of the body. That is what we call as in the, yes, tetany. Okay. So this is also not our answer. Yes, all of you have, few of you have given the correct answer. That is the increased melanin production due to the hormonal changes, which makes the linea nigra. Then what is the linea nigra? Linea nigra is the, yes, the this brown color line from symphysis pubis to the, yes, from symphysis pubis to the complete GP sternum. Okay. So this straight line from the symphysis pubis to the sternum or the GP sternum. So this one, what we, this line we, what we call as this one as the, yes, the linea nigra. Okay. So we call this one as in the linea nigra. Okay, so this occurs because of the the melanin hormone. Okay, so excessive melanin hormone in the pregnancy, which makes the skin changes like linea nigra. Okay, so that is because of the increased melanin production hormone in the pregnancy. Okay, all of you have given the correct answer. So then what is the stretching of the skin? Okay, so are you able to see the stretching of the skin here, students? Here, so the brownish discoloration stretch marks here, so pinkish brownish stretch marks here. Are you able to see this one? Yes. Yes, this stretch marks we call this one as in the striae gravidum. Okay, what we call this one as the striae gravidum. Okay, so these are the striae. Okay, so this pink color uh, rashes or the stretch marks, we say this one as a striae gravidum. And so this white color, are you able to see this side? So these white color striae are the the striae albicans, students. So which one will be there in the the current pregnancy? So which one indicates the previous pregnancy? So I have given the option A as the first image, and I have given the option B as the second image. So yes, you have to give the answer in the A or B. So which of the following image is giving the evidence of the previous pregnancy? Yes, is that option A or B? Yes, that is the option B, students. So striae albicans means white color stretch marks. So these white color stretch marks, which all are giving the the pregnant is this particular female is pregnant previously also. Okay, so this striae albicans. Okay, so sorry, this striae gravidum. So the pink or the brown color rashes, which are giving evidence of the female is currently now pregnant. Okay, so is that clear? Clear. Okay, so hope the concept is clear for this one. Yes, yes. So here is the next question. So what is the cloasma, commonly known as? So first you have to understand what is the cloasma, then we will go for the answer. Okay, so yes, I am giving the 30 seconds for you all to answer this question. What is the another name of the cloasma? Is this a liver spots? Is this a age spots? Is this a birthmark, or is this a mask of the pregnancy? So what is the answer for this one? Can anyone able to tell the answer? Yes. What is the cloasma? Cloasma is the mask of the pregnancy. Yes, some of you have given the correct answer. That is the mask of the pregnancy. Why I call this one as the mask of the pregnancy? Look at this image, students. This female, okay, she is a pregnant female because of the increased melanocyte. Okay, here on her face. Okay, so the mask like discoloration of the skin, or the mask like pigmentation of the skin will be there in the brownish color, and on both cheeks, nose and forehead. Okay, on the forehead and on the nose and on both cheeks, there is skin pigmentation is there in the pregnancy because of the again hormonal changes, melanin hormone changes. So this is what we call as in the cloasma. Okay, this is what we call as in the cloasma. So it is like mask. Okay, it is like mask. So we call this one as in the mask of the pregnancy. Okay, we call this one as in the mask of the pregnancy. That is the cloasma. Okay, is that clear, students? Yes, many of you have given the correct answer. Okay, yes, here is the next question. Let's try to give the correct answer for this question. Yes, so what is the cause of the physiological anemia that is observed in the pregnant woman? So what causes the physiological anemia that is observed in the pregnant woman, students? Yes, option A is that decreased iron intake. Decreased iron intake, it may leads to the pathological anemia, not physiological anemia. Okay, so decreased iron intake plus decreased folic acid intake, so which may leads to the dimorphic anemia. That is what we have discussed. The dimorphic anemia is a pathological anemia. So that anemia is the most common indirect cause of the most common indirect cause of the death in the India is that is the dimorphic anemia in the pregnancy. Okay, is that clear? Yes, the decreased iron intake and folic acid intake, which leads to the dimorphic anemia. Okay, this will not lead to the physiological anemia. Physiological anemia is the physiological means it is normal, it is not pathological. Okay, so then option B is that increased plasma volume. Okay, compared to the red blood cells. Yes, many of you have given the correct answer. That is the option B as the correct answer. That is the increased plasma volume is there as compared to the red blood cell. Remember, students, in the pregnancy, what happens? The 6.5 liter of the fluid will get retained, means the amount of the plasma. Okay, it will increases. Okay, this is the actual normal plasma volume, and here is the number of the cells as a 3. Just consider for example purpose. Okay, but what happens in pregnancy? The plasma will get increases till this much, means the 50% of the plasma level will increases, and only yes the 25% of the red blood cell increases. Yes, the number of the red blood cell increases or decreases means it is also increases. Okay, the amount of the plasma increases or decreases means it is also increases, but the plasma increases more than the yes the red blood cell. That is what again it may leads to the dilution only. Okay, so again in the hematocrit means yes the concentration of the blood will remains low only. Okay, so that is in the dilution form only. Okay, so this is what when we'll take the sample and sends to the lab. Okay, so this may leads to the because of the dilutional sample, so there is it shows the less hb in the pregnancy, but less means it will never go less than 11 grams, students. If the hb less goes 11 less than 11 gram means, so we call this one as in the pathological anemia. Okay, yes, pathological anemia. Okay, so it may be 11 to 12 grams per deciliter will be the yes it will the range of the physiological anemia. It will not goes behind the 11 gram. If it is going goes behind the 11 gram per deciliter means less than 11 gram per deciliter and below means we call that one as in the pathological anemia. Okay, is that clear? Because it occurs because of the increased plasma volume as compared to red blood cell. Red blood cell also increases, plasma also increases, but the plasma increases more than the red blood cells, so which may leads to the yes the physiological anemia. Okay, so what is the cut up hemoglobin for the physiological anemia? Yes, that is the 11 to 12 gram per deciliter, and if it is going less than 11 gram per deciliter in the pregnancy, that is what we call as in the pathological anemia. This is a basic and important concept you have to okay remember for your future exams. Okay, so here is the next and best question for you all. Okay, which of the following decreases in pregnancy? So which of the following decreases in the pregnancy? Okay, so many things we have discussed already. So just you have to give the correct answer now. Okay, so consider this one as in the 10-star question for you. So which among the following will get decreases in the pregnancy? Option is that RBC. Just I had told that the number of the RBC will be increased, but it is in the diagnosis means it is in the dilutional form. It will not seen, but the number of the RBC will get increased in the pregnancy. Okay, and the number of the WBC, students, what is the normal WBC level? That is the 4,000 to the 11,000. Okay, so is the normal WBC level. Okay, so this is the normal WBC level, but in the pregnancy it will go till the 80,000, students. So the WBC also increases in the pregnancy. Then what I told, the clotting factors, all clotting factors, okay, increases in the pregnancy except 11 and 13. So total we are having 13. Among the 13, so the 11 or 11 clotting factors, all clotting factors increases means, so we'll consider the clotting factors are increasing in the pregnancy. Then globulin, I told that in pre-pregnant women the albumin is to globulin ratio is the 1.7 is to 1. Okay, so in the pregnant woman it is 1 is to 1, means the albumin will decreases and globulin will increases. So what I told here, the globulin will increases. Already I have discussed in the first or second question, I think so. Okay, yes, so the only one thing that will decrease is the platelet. Okay, platelets will get decreases in the pregnancy. So because of that, this one we call this in the pregnancy as a benign, okay, benign renaldic thrombocytopenia. Okay, so also we can say this one as the benign gestational thrombocytopenia. Okay, so what we call this one as in the benign gestational thrombocytopenia. Okay, so this is the very important, you have to know the platelet only thing that will get decreases in the pregnancy, and RBC, WBC, clotting factors, globulin will increases in the pregnancy, and platelet, then T lymphocytes, then albumin will get decreases in the pregnancy. So other physiological changes in the pregnancy will again discuss in the next video. So I think so this video helped you a lot. Okay, so if anyone is new to this channel, so I have given the link for to join my telegram group. You can join by that link. Okay, so if anyone is new to this channel, so don't forget to subscribe to the channel. Okay, if my struggle helps you, if my struggles is really helping you to boost your marks, so don't forget to hit the like button, and so please write your honest comment after the end of this class. Okay, so that actually helps me to whether to improve the content still more a lot, or this is the sufficient for your understanding purpose. Okay, so I will make more creative things if you suggest me. Okay, so don't forget to comment your review in the comment box. Okay, I will be waiting for your comments. Okay. Students, so we'll wind up the today's class here. We'll meet again in the next tomorrow's class. Okay. So don't forget to join morning 6:30. Remember, I will be waiting for you all. Okay. So yes, thank you so much. Okay. Thanks for your love and loss. Okay. So we'll meet again in the tomorrow's class. तब तक के लिए जय हिंद, जय भारत.